Hello, all. Okay, so again, I've never done a lecture like this before, so please be kind. A couple of things before we get started. I think some people had a couple of questions about the paper that is due pretty soon. I think some of you have already turned it in. If you have turned it in and you want to resubmit after this little chat that we're about to have, that's fine. I just need you to email it to me and let me know that this is the second copy. And that it's the one to be graded. So I don't know, some pretty general things. We talked about the paper. Let me find my notes real quick. We talked about the paper very early on in the class when we talked about when we did the syllabus. Basically, what you probably already know is that you got a scenario is on Danny and Laura and Kid. And the first part of it is that you are to briefly summarize, provide an assessment of the case study. You don't have to rewrite the entire thing. This is a half a page. So just kind of give me like the high points, what you think the important things are, who we're dealing with. Again, kind of like you were writing an assessment, not a book report, not a synopsis. The second thing is that how should you as a social worker address the identified problems that you've noted? So again, you've got to keep in mind that you're now a social worker. This isn't a friend. This isn't a relative that's come to you with this issue. So you're going to do it in an empathetic. You're going to do it in a non-judgmental way. So kind of keep in mind those things that you learn from Intro to Social Work, what social workers are about. The third thing, what theoretical perspective could best be applied to this case study? Use at least 3 examples from the case study to support your choice. So the next part of that is that you need to do a strengths-based piece on this as well. So obviously don't choose, strengths perspective as the first one. So what it's asking you to do, you choose one. Choose a theoretical perspective and use at least 3 examples from the case. I can't really give you examples of this because if I did, then there aren't that many. But look at the perspectives. What do you think best fits this? And then again, give some specific examples from the scenario, from the case, as to why you think that would work. Once you've done that, then you move on to the strengths perspective. And depending on who you choose to really focus on in this, you don't have to do strengths for all 3 characters. Just choose a character. Some of their strengths are more obvious than others. So if you choose one that's less obvious, don't be, scared of that because all clients have strengths. Finally, the next part is that you need a minimum of 2 APA formatted resources or references. These need to be peer reviewed. And, obviously whatever you choose, make sure that it goes along with, whatever thought that you're trying to convey in this. And then finally, mechanics, grammar, and spelling, punctuation. I highly encourage you to use that thing on Word. It's the grammar check, spell check. Use that. Another thing I would encourage you to do, you may still have time, might be a little tight at this point, but certainly now or for future papers, we have the Writing Center over in the library, on the first floor of the library. So if you're struggling or, concerned or anything like that, then certainly make an appointment with them. Okay, so that kind of goes back over the paper a little bit. The other thing too is that I'm really noticing like a massive glare like on my glasses, but if I take the glasses off I can't see. So again, I apologize. You probably just have to live with the glare for a little bit. Okay, so chapter 2, conception, pregnancy, and childbirth. Typically what I would do if we were meeting face to face is that I would kind of throw this question out there. So if you were a social worker and you were practicing social work, as we hope you will be one day, what do you think are some of the issues or problems that people might come to you with in regard to this particular developmental stage. So again, it's conception, pregnancy, and childbirth. So normally I would give the class a little bit of time to, kind of come up with some answers and things like that. But since you're not live with me, I'm going to kind of provide those for you. One other thing too, I'm actually doing this at my house, and occasionally you're going to hear my dog bark, or maybe my husband like playing with a dog. So again, I apologize for the distractions. Okay, so you're a social worker. Some of the and this is not all, but some of the things that you might end up working with clients in terms of this particular phase of life, um, definitely fertility issues. It seems to be a growing thing. Probably has been happening for a long time, but more and more people are coming into services because of concerns about not being able to have children. Um, so that's definitely one issue that you might be working with. Other issues that you might be working with is that individuals may have found out that they're pregnant and now they're considering an abortion, and or they were pregnant and they had an abortion, and so now there may be like guilt or other kinds of issues, wrapped up in that. So obviously that would be something they might come to you for. Um, Also, there is the chance that you may come across clients that have found out that they are pregnant and they've done some type of genetic testing, and they know that their child is going to be born potentially with intellectual disabilities, or other types of other types of problems. And so they really just may need to come to you to, kind of like talk that through. Like, how do we deal with this? What are resources? That type of thing. You're also oftentimes going to get maybe younger individuals that are not married. Maybe they're teenagers and they're coming in, and maybe you find out for the first time that they are pregnant, or maybe that's what the problem is. They come in and like, how are we going to tell our parents? How is all of this going to work out? Gosh, there's a lot more. A lot more, but those are just some, just sort of scratching the surface of things that you might need to consider, that you might be working with this population. Postpartum, that's another big one. After childbirth, maybe a mother doesn't feel like that she's bonding the way that she should. If you work in a hospital setting, it could be that the doctors may approach you and say, really want you to do an assessment. Don't really feel like that this mom and baby are, bonding, that they're forming that attachment like, we would typically see. So again, those are things that you need to keep in mind when you are working with individuals in this life stage. Okay, so I'm going to kind of follow along with the PowerPoint slides that you have. So the one that we're going to talk about right now is the sociocultural organization of childbearing. So what it says, the social constructionist perspective, social reality is created when people in social interaction develop shared meaning, a common understanding of the world. So cultural groups develop common understanding, and then there's various factors that influence pregnancy, childbearing, technology, increasing diversity, and things like that. So basically what social constructionist theory is saying is that within every culture, there is sort of this construct, or sort of this idea of what is typical, or what is the norm. And in our culture in the United States, when it comes to things like conception, pregnancy, childbirth, I mean, we still have sort of these sort of time-honored ideas, but the ideas of that really are changing. And one of the ways we look at this is in terms of family and the concept of family. Traditionally, family was seen as a mother, father, offspring, sometimes extended family. But as you know, now family really takes on a whole bunch of different, there's a whole bunch of different varieties of what we would consider to be family. And so, how we look at that and how we deal with that from a social constructionist point of view really is that society very much helps us to construct and to maintain these ideas. Also, within social social constructionist theory perspective, not only like what I've just talked about, but then it also kind of like dictates who can marry, who should have children, what age you should have children. So again, this reality thing, this reality piece is much larger than than we sometimes really realize. Okay, so conception and pregnancy in context. Conception experience is influenced by expectations of the parents, organized religion, social customs, changing values, economics, political ideologies. There was, for many years, like, pregnancy and becoming, a new mother and forming a new family was portrayed in the media and in television programs in a particular way. And now it's not always the same way. It's not always the same way for each person. Another thing you have to keep in mind in social work is that when you're working with individuals, even though there is this social construct and sort of these social ideas, you also have to realize that each and every person is unique, and how they respond to these things is going to vary. Um, One of the things that we know now is that there's an increasing trend for women who have, for whatever reason, not gotten married. Maybe they put a career before education, whatever. And so now they're at a certain time in life and they're thinking, I really want to have a child. And so now there are means for them to have a child without necessarily being in a relationship. So again, those are things that you really have to consider. And each of these things is very unique to different individuals. Also, we talk about childbirth in the United States. I'm sorry, childbirth education. If you want to start all the way at the beginning, I don't know what your experiences were with sex education in school, but mine was pretty limited. I remember in 5th grade, they separated the little girls from the little boys. Little girls went in one room, little boys went in one room, and so they showed a film. And so but we didn't see it together. So the film that the girls saw was something like, it was like a little flower, and this little bee buzzed over the flower and dropped some pollen or something, and then all of a sudden there was all these little bitty flowers beneath the big, I guess, mother flower. And then the guy's video, best I remember, had something to do with like a cactus. I mean, I'm not kidding. That was sex education. We get to 8th grade and they have a reproduction section in biology, but again, if all I knew about reproduction was based on those two encounters, those two experiences, I really would not know that much. In many schools now, sex education really is much more formatted, much more intensive, much more informative. But it's still one of those difficult things, I think, a lot of times in families for them to discuss, and just sort of the pressure that we put on people in terms of sex and sex education. It makes it difficult sometimes to get all that across. Okay, so again, I'm going to let you kind of, I'm not going to read every one of these slides to you. I mean, obviously, the way that we look at conception, the way that we look at even childbirth now has changed over the years. The slides refer to once there was a trend toward midwives. We're kind of coming back to that, but it's still now even in a medical setting. So majority of individuals now are actually born in hospitals in the United States. With medical care, treatment, there's prenatal care, there's all these different things in terms of medical advances. So obviously it has changed considerably, over time. There's also some discussion in here on genetics. Starting, oh goodness, well, I mean, really earlier than we realize, they begin looking at the idea of genetics, like how are like family traits passed on. How is it that you have red hair and blue eyes, or someone else has dark hair and dark eyes? So we really began looking at that early. But then, certainly in the 80s, really began looking at this concept of DNA and all of the genetic parts of this that go together. Again, there's a big slide on this. Talks about phenotypes. Phenotypes are observable traits. So if you look at an individual and they have, like light skin and blue eyes, that's part of the phenotype. Um, Interestingly, though, enough, is that, well, this may be for a different discussion, but a lot of times we try to change the phenotype. We make our skin darker, we make our skin lighter, we make our hair darker, lighter, we wear contact lenses. But the phenotype really is generally what we would consider those base observable traits. Sex chromosomes. Again, there's a whole big slide on this. You you probably, I know that if you're in social work now, you've had biology at least in the last little bit. So you talked about the chromosomes and the genetics and the makeup and the sperm and egg and how all that works together. So I'm not going to spend a lot of time on that. Um, but again, along the lines of genetics, there is, particularly at certain age or people that are maybe at greater risk, there is genetic counseling that goes on. And so a lot of times individuals really know pretty early on if there's going to be problems in their pregnancy, if their child is going to have temporary or permanent problems after childbirth. So you will deal with that from time to time in social work. Control over conception and pregnancy. Again, it could be that you may end up seeing individuals because of this. Religion a lot of times plays a key factor in this. Maybe the religion says that you cannot use contraceptives, and so now they're concerned about, well, what if I get pregnant? Or but and again, this may seem kind of a little off target sometimes in terms of social work, but people come in to see you with the problems that are problems for them, things that they feel are, weighing on them in some manner. What else do we have? Okay, yeah, so it goes through the different types of control over conception and pregnancy. So breastfeeding, periodic abstinence, vaginal rings, IUDs. Just kind of be familiar with what some of those would be. Also, again, I talked about this already. Abortion is one that people may come in and want to talk about. They found out that they're pregnant for whatever reason. They do not want to have the child. And so they've come to you because they are scared, they're guilty, whatever the emotion is, they come to you. So at this point, as social workers, almost anything somebody comes to you about, you probably have some type of feeling or reaction to it. And of course, abortion is one of those big ones. Most people don't really go middle of the road. They're either for it or they're against it. And if you have someone that is coming in and they are considering doing it, and you are not somebody that believes that that is appropriate, you have to be careful. These individuals are in a very vulnerable position, and you have to be very delicate in how that you approach it. And again, this is one of those professions where we try our very hardest to leave our own judgment out of things, to not be judgmental. And we know abortion is a big topic. Currently, right now, if you have followed the political landscape at all, they are looking at bringing in a new justice into the Supreme Court. And as always, when they bring in someone that is, one of the big lawmakers, they want to know what their stance is on these big topics: capital punishment, abortion, Uh, so yeah, that is always going to be in play, and realizing that and working within that. Infertility, and again, I think a lot of times we think of infertility that when clients come in, the infertility is going to be with the female. A lot of times, the infertility issue is actually with the male. And again, if you think about socialization and you think about how that we are taught early on, men are strong and they're in charge and, all of these things. Um, for a man to find out that he is not able to produce children can be a very, very extreme and difficult, life altering um, thing for them to learn. So, don't be surprised if that is a problem. Not just infertility and impotence. Anything along those lines. Be prepared for. Okay, so there's also a slide. If you well, okay. Anyway, it's entitled "Control Over Conception and Pregnancy: Infertility Treatment Continued." It talks about male causes, medical causes, female causes, medical. So, kind of look over that slide as well. Fetal development, gestation, fertilized ovum becomes fully developed infant around 40 weeks. And so sometimes children are born, prematurely, which, obviously may potentially cause harm to the child, or, there may be complications with that. Fertilization age, first trimester, second trimester, third trimester. So again, as the baby develops within the mother, different things can happen with the child, but then also different things can actually be happening with the mom too. So childbearing age for most women is 15 to 44. Do not be shocked if you one day get a child that comes in and they're 12, 13 years old and they're pregnant. At that point, you are going to really have to do some investigating because you may end up having to be a mandated reporter, particularly if the father of that child is, of a certain age. Also, don't be surprised if, one day you don't have a mom that comes in that, a pregnant mom that is, well into her 50s. When we say that the average age is 15 to 44, it doesn't mean it can't happen before or, that it can't happen after. But for a 55-year-old woman to find out that she's pregnant, again, can produce a good deal of anxiety for some people. There's also dealing with at-risk newborns, prematurity, low birth weight. Again, kind of keeping in mind, and some of you, I figure, are probably going to want to work in a hospital setting, and so you may get, a lot more like firsthand knowledge just working in that setting than you would probably actually get in school. So again, issues with ongoing issues or potential issues with the child after it's born. Also working with gay and lesbian couples. They are families now, and like a lot of families, they want children, and they have different options about getting children, but still sometimes there is difficulty in that. Or if an adoption or something like that along those lines is failed, then a lot of times they may need treatment as well. And working with families in that could be a big part. Special parent populations, substance abusing pregnant women. We would love to think that the moment that a woman found out that she was pregnant, that she would stop using all substances. Tobacco products, illicit drugs, anything like that, even caffeine. But that doesn't always happen. And so this is a special population. In fact, we're actually working on a study now that looks at minority women, pregnant minority women, and smoking cessation. There are a lot of techniques out there, a lot of therapeutic interventions that work with that. but there can really be a lot of guilt, associated with this, particularly if they're trying to hide, their use of anything from family members. So again, being aware. Eating disorders among pregnant women, also a special population. Incarcerated pregnant women. Um, Starting like in the mid 90s, there was just this incredible increase in the number of women in prison that were being incarcerated, for starters. And being incarcerated, a huge number of women that were already pregnant, and a huge number of children that were actually born in jails. Um, so what happens after that then is that, depending on how long the mom's sentence is, child either goes into foster care or goes to live with family. And a lot of times it's the family that's reaching out. We have this child, there's some issues going on, particularly if mom was using drugs. And so you have like fetal alcohol syndrome, a whole host of things that can come about. Again, sometimes working with the mom, if she's been reunited with the child after being incarcerated, or working with the family that has received the child. HIV. For years it was believed that if a woman was HIV positive and became pregnant and had the child, that the child would automatically be HIV positive as well. And that's not necessarily the case now. We have methods of, ensuring that doesn't, or for the most part, ensuring that doesn't help, that doesn't happen. But again, if you have a mom that has HIV, or potentially has been like diagnosed with a terminal disease of some sort, cancer, they are oftentimes going to need resources. They're going to need what social workers can provide. Okay. Shockingly, looks like I did this in about 27 minutes. That's not too bad. For the most part, that is that particular chapter. I think if you look at the syllabus, and let me look at that real quick. I apologize. I should have already done that. I'm looking at when the exam. Okay. So on the syllabus, it says that exam 1 will cover chapters 1 through 3. And since we have not covered 3, and I don't want to do chapter 3 like I'm currently doing chapter 2, the exam is going to cover chapters 1 and 2. And I will try to remember, I'll send this out in an email as well. So it's going to cover chapters 1 and 2. Probably 20 to 25 multiple choice questions. Nothing is going to be I don't believe in like tricky questions, anything like that. I'm not trying to test your ability to take a test, but I am testing your ability to read the material, to understand the material, comprehend it, and the material being the textbook, as well as PowerPoints, lectures, any kind of notes that you might have taken, during classes. So again, 20 to 25 questions, all multiple choice. We will do it obviously in the classroom. If there's other accommodations that need to be made, we can certainly do that. Not a problem at all. You will have the full hour and 15 minutes to take the exam if you do it in the classroom. And I just ask that once you finish the exam, that if you want to like talk with your classmates about it, that you do it somewhere other than outside the door. So, go down the hall or go to the second floor and hang out or whatever, but just try to be respectful of, the ones that are still taking the exam. And even as you finish the exam, if you'll, kind of collect your things quietly and all that. We're going to try to start right on time. My general rule is that once the first exam has been turned in, then anybody coming in late after that is not going to get to take the exam. So make sure that you're on time. If you have questions, concerns, anything like that, please, please, please email me. Again, I'm pretty good about getting back from email with email. I do apologize for last week. I had surgery on Wednesday and just truly believed that I would be 100% ready to go, and that was not the case on Thursday. So, again, this is not my preferred method of doing a lecture, but I hope this works, and I will see you next Thursday.